Welcome back to the deep dive. You've handed us some incredibly detailed material, and today we're diving deep into a corner of surgical practice and medical coding that, well, often goes unexamined.
That's right.
We're talking about the nuanced world of adjacent tissue transfers. Think of it as, I guess, the surgical art of skin reconstruction, and how every single decision has a precise coding implication.
It really does. It's fascinating stuff.
Okay, so let's really unpack this. When we think about fixing wounds, our minds often jump to simple stitches, right? That's the common picture.
Standard closure.
But sometimes a straightforward closure just isn't enough.
Yeah.
We're talking about procedures where a surgeon meticulously moves and reshapes existing healthy skin from a nearby area to repair a defect.
Yeah.
It's truly ingenious when you think about it.
Absolutely. And far more intricate than it sounds.
Right.
Yeah, and this deep dive is really designed to pull back the curtain on these highly specialized techniques, known formally as adjacent tissue transfers or rearrangements.
Okay. ATTs for short, maybe?
Exactly, ATTs. And critically, we're exploring the very specific guidelines for accurately coding them. Because understanding these nuances isn't just, an academic exercise.
No, definitely not.
It's absolutely crucial for accurate medical billing, for truly reflecting the complexity of the surgeon's work, and ultimately for ensuring patients can access these vital procedures.
So let's start with the basics then.
Yeah.
What kinds of procedures actually fall under this adjacent tissue transfer umbrella? I've seen terms in the sources like Z-plasty, W-plasty, VY-plasty, rotation flaps, random island flaps, advancement flaps. Just hearing those names, it sounds like a highly artistic, almost architectural kind of surgery.
It absolutely is. That's a perfect way to put it. We're talking CPT codes in the 14,000 to 13302 range.
Okay.
And these aren't for situations where a surgeon simply stitches a wound directly closed. No. Instead, therefore, when a surgeon deliberately plans and executes the movement of a section of nearby healthy tissue, that adjacent tissue to repair a defect.
So it's planned, deliberate.
Yeah. Deliberate. It's about literally reshaping and rearranging the local tissue to achieve a tension-free closure and reconstruct the area. And what's really crucial here is that the guidelines emphasize this must be a deliberate surgical technique.
Right.
Performed by the surgeon to accomplish the repair. It doesn't apply to just, say, an incidental outcome of a traumatic wound or a simple closure. It requires precision, both in the OR and in the documentation afterwards.
That distinction between deliberate and incidental feels really important. It highlights that these aren't just like advanced ways to close a wound, but specific reconstructive strategies.
Precisely. And that leads us right into another area where precision is absolutely paramount: measurement.
Yes, measurement. The materials you shared really highlighted the complexity here, especially when you have what they call primary and secondary defects. How do surgeons and then the coders figure out the size for billing? Sounds like you'd get tricky fast.
Yeah, this is an important question for coders, and honestly, often a point of confusion. So for code selection purposes, the term defect isn't just the original hole or the damaged area.
All right.
It actually includes both the primary defect, that's the original spot where tissue was removed or damaged, and the secondary defect.
Secondary defect, that's the donor site.
Exactly. The secondary defect is the area created when the surgeon harvests or designs the flap from the adjacent tissue to do the reconstruction. You add these two measurements together.
Okay.
Yep, add them together to get the total surface area, and that's the number you use to select the final CPT code.
Okay. Let's make this really concrete then. Imagine a surgeon removes a lesion, maybe a skin cancer, right? And then uses an ATT to close the wound that's left. How do you code that? Do you code the lesion removal and the ATT separately? Because it feels like two distinct things happened.
That's a critical point, and actually the guidelines are very clear on this. The excision of a benign lesion, codes like 11-1-400, Leonard 11446, or a malignant lesion, codes Lev 1600, 11646, is not separately reportable when it's performed with an adjacent tissue transfer, those 14,000 14302 codes.
Not separately reportable, so it's included.
It's included. The ATT code itself is considered to inherently include the excision of the lesion. It's bundled in. So you wouldn't report both codes.
Right.
You just report the ATT code because that reflects the greater complexity of the entire procedure, the removal and the reconstruction.
Wow, that's a massive detail. Getting that wrong could lead to some serious billing headaches, maybe even audits for a practice.
Oh, absolutely.
So the ATT code basically covers the whole package. removing the problem and then rebuilding the area with nearby tissue.
Exactly right. It recognizes that the primary surgical effort and, the real expertise lies in that reconstructive aspect.
Okay. What about other repairs then? The sources mention skin grafts being necessary sometimes to close a secondary defect. Are those also bundled in, or are they separate?
No, that's different. That's where the bundling rule has a specific and very important exception.
Oh, okay.
If a skin graft becomes necessary to close that secondary defect, remember, that's the donor site where the flap tissue came from, if you can't just stitch it closed directly.
No.
That is considered an additional separate procedure.
So you do code that separately?
You do. In that scenario, you would report it separately using the appropriate skin graft codes, maybe something in the 1TI00 to 15278 range. This is because closing that secondary defect with a separate skin graft adds a significant, distinct surgical effort. It's beyond the scope of just the initial ATT.
Okay, that makes sense. You're bringing in tissue from another part of the body or a different type of graft to close the donor site of the flap itself. That does sound like a whole different ballgame.
It is.
So if the flap donor site needs its own graft, that extra step gets its own code.
Precisely. It's all about recognizing the distinct surgical efforts involved.
Okay. Now, another area that really stood out in the materials was the distinction between these adjacent tissue transfers and what's called a complex repair. It seems like undermining alone is the crucial differentiator there. Can you shed some light on that? Because it sounds like something that could easily be confused.
You've absolutely hit on a very common point of confusion, especially for newer coders. And it's where meticulous documentation really, really shines. So undermining tissue.
Such as loosening the skin underneath, right?
Exactly. Separating the skin from deeper structures to allow for a tension-free closure. It's common. It's vital in many repairs. Helps bring the edges together. However, the guidelines are quite explicit. Undermining alone of adjacent tissues to achieve closure without additional incisions does not constitute an adjacent tissue transfer.
So if a surgeon just loosens the skin underneath to pull the edges of a wound together, that's not ATT, even if it's like extensive undermining.
Correct. If only undermining is performed without those specific deliberate incisions and the rearrangements that are characteristic of, say, a Z-plasty or a rotation flap.
Right, those named techniques.
Yes. Then it would typically be coded as a complex repair using codes from the 13100, 13160 range. The core distinction, the sort of aha moment here, is whether new incisions are made to actually rearrange the tissue, to create a flap that moves into the defect rather than just simply loosening the existing tissue around the wound to facilitate direct closure. If you're creating a new design, shifting skin around like a puzzle piece.
I like that analogy, puzzle piece.
Then that's your ATT. If you're just, stretching and releasing the existing edges, it's more likely a complex repair.
That's a fantastic way to put it. It really clarifies the intent behind an ATT. It's about structural change, not just tension release. Okay, now, diving into the actual codes themselves, it looks like the body area and the size of the defect are hugely important in picking the correct ATT code. This is where it gets very granular, isn't it?
Oh, absolutely granular. The adjacent tissue transfer codes are meticulously categorized, not just by the technique, but by specific anatomical regions, and, of course, the total surface area of the defect, remembering that's primary plus secondary defects added together.
Right.
It's basically a way of recognizing that, a 5 square centimeter repair on your eyelid is vastly different in complexity and skill required compared to a 5 square centimeter repair on your leg.
That makes perfect sense. The delicacy of the area, the functional importance, it's all factored in.
Exactly. So let's walk through some of those key distinctions.
Okay.
For the trunk, which is generally less cosmetically sensitive, maybe has more tissue available, you'll find codes like 14,000 for a defect 10 square centimeters or less, and 14,001 for defects from 10.1 up to 30.0 square centimeters.
Okay, trunk.
Then, moving to areas like the scalp, arms, and door legs, the relevant codes are 14020 for defects 10 square centimeters or less, and 4021 for that 10.1 to 30.0 square centimeter range. Again, different coding structure, reflecting potential scarring, functional impact.
Right. Then we get into more intricate areas. The forehead, cheeks, chin, mouth, neck, axillae, armpits, genitalia, hands, and/or feet. That's a big group. Yeah, quite a mix there, hands and face especially. Exactly. These are grouped under codes like 4040 for defects 10 square centimeters or less, and 44041 for the 10.1 to 30.0 size. Yeah. You can just imagine the increased precision needed there. Definitely. And finally, the arguably even more delicate and functionally critical areas. The eyelids, nose, ears, and/or lips. These use codes like 446D for 10 square centimeters or less, and 446.1 for defects between 10.1 and 30.0. These are areas where even tiny changes can have huge functional or cosmetic consequences. That's quite the breakdown. So the physical location, the real estate, really elevates the complexity and, by extension, the coding. What about really large defects? Do they just keep going up, or are there separate codes?
There are specific codes for larger ones. For significantly larger defects covering any area, the primary code is 14301. That covers defects from 30.1 up to 60.0 square centimeters.
Okay, 30 to 60.
Right. And if the defect is even bigger than that, you'd use an add-on code, 14302, for each additional 30.0 square centimeters, or, any part thereof. This allows for accurate reporting of really extensive reconstructive work.
Gotcha. And I noticed one code in the list that sounded, well, pretty unique. 14350 for a filleted finger or toe flap. That name alone conjures up a very specific, maybe slightly grisly image. What's the story there?
That's definitely a standout. A filleted finger or toe flap is indeed a highly specialized ATT technique. It involves essentially deboning a severely damaged finger or toe,
Wow.
and then using the remaining soft tissue and skin, the fillet, as a flap to reconstruct a neighboring, more salvageable digit or cover a defect on the hand or foot.
Incredible.
It really is. It's a testament to the ingenuity and surgical skill involved in limb reconstruction, and it highlights just how detailed and specific these coding guidelines need to be to precisely capture the incredible complexity of the work right down to individual digits. It's not common, but when needed, it's vital.
Wow. It is absolutely clear that coding adjacent tissue transfers isn't just about picking a number from a list. Not at all. It demands a deep understanding of the surgery itself, the precise location, meticulous measurements, including how you combine primary and secondary defects, and knowing when extra procedures like skin grafts for the donor site are separate. It truly underscores the immense expertise needed in medical coding.
Absolutely. And if we connect this to the bigger picture, the really meticulous nature of these coding guidelines ensures that the highly skilled, often incredibly delicate, and absolutely vital work of reconstructive surgeons is accurately valued and, importantly, reimbursed.
Right.
Getting these codes right directly impacts the ability of healthcare providers to actually offer these critical services to patients who need them, maybe after trauma or cancer, needing functional and aesthetic reconstruction. It's not just about the money, it's really about access to care and sustaining these specialized surgical practices.
So what does this all mean for you listening? Well, next time you hear about a complex wound repair or some kind of skin reconstruction, you'll know that beyond the surgeon's incredible skill with a scalpel, there's this whole universe of detailed decisions happening behind the scenes. From that initial measurement of both primary and secondary defects, to understanding the bundling rules for lesion excision and differentiating between an ATT and maybe just a complex repair, every single choice influences the entire billing process. And this level of precision where knowing the difference between just undermining alone and a deliberate flap creation can literally mean thousands of dollars or complete denial in billing. It just reveals these hidden layers of expertise that underpin every single medical procedure. It's a stark reminder that even a tiny flap of tissue can unlock a whole labyrinth of coding challenges and financial implications.
Well said.
And that's another deep dive complete. We hope you've enjoyed this fascinating and maybe slightly intense exploration into adjacent tissue transfers and their intricate coding guidelines. Keep those sources coming, and we'll keep unpacking them for you.